This was given to the postgraduates and junior consultants on the occasion of continuous medical education program of Harnam Singh midterm program conducted by Indian College of Radiology and Imaging in association with the IRIA AP branch and KREST. So we have to know what are the various metabolic disorders that we encounter commonly. Vitamins play a major role, so hypovitaminosis, hypervitaminosis, minerals, calcium, phosphorus, aluminum, metals, again iron, etc. Hormones, all hormones from pituitary, parathyroids, thyroids, pancreas, and adrenals, almost all the hormones. Enzymes, enzymatic deficiencies, very common. Acidosis, Wilson's disease. Like that, there are several enzymatic deficiencies, even Gaucher's disease. Other miscellaneous causes producing changes in the human body because of the metabolic disorders, particularly in the bones. And then nutritional. Vitamin deficiencies, vitamin D deficiency, for example, Rickets, C, Scurvy. Rickets in children, vitamin D, but in adults, osteomalacia. Kwashiorkor, complete dehydration and atrophy of the muscles. Cirrhosis of the liver. Hypoproteinemia, very common in India. Anemias, not only hemolytic type of anemias, but microcytic anemias. Hypovitaminosis. Other vitamins other than D and C. Rickets. What is the etiology of rickets? Not necessarily dietic, but dietary. All right, the patient or the child takes enough diet, but it will not be absorbed properly in the intestinal tract. So any disorder in the intestinal tract can produce rickets. Having absorbed, it will not be utilized. There are two stages of utilization. One, the liver. Two, finally, in the kidney. So if there are problems in the liver or in the kidney, rickets may result. Deficient enzymes such as hypophosphatasia. Alkaline phosphatase is low, so you get deficient hypophosphatasia. Excessive excretion in the urine also produces. And there are miscellaneous causes. And then, as we said earlier, lack of intake, lack of exposure to sun also, particularly in certain communities, is very common. Lack of absorption, we have told already. Lack of stage 1 metabolism in the liver, stage 2 metabolism in the kidney, and lack of enzymes. So what are the changes? In the growing skeleton, it is called rickets. In adults, once the maturity is over, we call it osteomalacia. Generalized lucency. And then occasional density also, increased density is also noted in rickets, as though to compensate for the deficiency of calcium, the osteoid excess will be there. Ground glass appearance of the bones. See, normally in osteoporosis, the cortex and spongosa, they are well differentiated. Whereas in rickets, ground glass appearance of bones, physical lucency, the distance between the metaphysis and epiphysis is increased. That's the physis, because of the excessive osteoid and lack of mineralization. Metaphysis, that results in metaphyseal cupping. For example, look at both the knees. Classical example of rickets. Classical in the sense metaphyseal cupping is there. Distance between the metaphysis and epiphysis is increased because of the hypertrophied physis. And then look at the epiphysis. You can't draw a real cortical line. It's all absorption or lack of cortex. Paintbrush appearance in the metaphysis. These are columns of cartilage which are partly calcified, partly not calcified. Osteoid seams, wherever there is a vessel that passes through the bone, for example, here nutrient vessels, can produce so-called loser zones because of the osteoid seams. Osteoid seams which are not mineralized properly. Absence of lamina dura in the teeth, delayed growth and maturation, most of the rachitic children, so underage. And then periosteal reaction as though to compensate, or even if there is softening of the bone, to compensate that bowing, periosteal reaction and new bone formation is formed. Classical example in the wrists, because they're active, babies are active. So the most important findings are noted in the wrists. Again, cupping and ground glass appearance of the bones. And although the infant is 1 year old, still only one ossification center is noted for the corpus, that too very small. Deformities of bones, because there is softening, when the children walk, there is bowing of the legs, frontal bossing, and then rachitic rosary along the costocostal frontal junctions. There is hypertrophied osteoid, as we said earlier, non-mineralized, so that produces cupping, and clinically you can palpate these beads as if there is a rosary bead. Fractures are common, and ultimately these, if neglected, lead to secondary hyperparathyroidism. Classical example of rachitic rosary, one on your left side is this specimen. The child died unfortunately, and you see the cupping of the anterior ends of the ribs with hypertrophied osteoid, producing a beaded appearance. Similarly, in the chest film, you could see the beaded appearance. Earlier I was telling you, there is a bone marrow hypertrophy in the frontal bone, non-mineralized osteoid. Though it is soft, that's why they also call it craniotabes. Again, in the knees and legs, because there is softening, we find deformities at the lower ends of the both legs. And then, not necessarily dietary rickets, now we go to the renal tubular acidosis. With the proximal or distal tubular deficiency, you may get rickets. Only difference between dietary rickets and renal tubular acidosis is generally the osteomalacia or the lucency of the bones is not that much in renal type of rickets. Otherwise, you can't really differentiate between these two. Same thing occurs in the pelvis, but here it is vitamin D resistant rickets, otherwise called familial hypophosphatemia. You can go riddles. There are several clinical features as well as radiological features also in vitamin D resistant rickets. The bones are usually short, dumbbell type, as though sometimes it may resemble achondroplasia. Now we come to the adults. Rickets is nothing but childhood osteomalacia, or osteomalacia is nothing but adult rickets. Generalized lucency, as we saw in the rachitic phase in the bones, occasionally increased density because of the excessive osteoid, as though to compensate for the calcium deficiency. Increased density may also be noted. Ground glass appearance, no differentiation between the cortex and spongiosa, osteoid seams, so-called looser zones, and deformities due to softening of the bones. Almost similar appearances, but these are gross. For example, look at the pelvis. Osteomalacia is more common in women rather than men. Look at the deformities of the pelvis, almost a triangular type of pelvis, yields looser zones, and look at the femora, transverse lucencies, one on the left and one on the right at the bottom. These are called looser zones or osteoid seams, and as though it is healing, there is excessive callus. The patient is on therapy, osteomalacia on therapy. And then, as we have said already, there is lack of differentiation between the cortex and spongiosa. Endosteal and periosteal new bones also may be noted. Para-articular calcifications. Earlier in dietary rickets, we didn't see the calcification. Here in osteomalacia, occasionally you can see para-articular calcifications. Real fractures can occur and pseudo fractures can occur, and eventually this also leads to secondary hyperparathyroidism. Please note, the findings are almost same as rickets in children. Focused view of the pubic symphysis area. Look at the bilateral symmetrical osteoid seams or looser zones with osteomalacia. In general, in osteomalacia, there is also, because of the deficiency in nutrition, there will be osteoporosis. There's a combination is there, but predominantly osteomalacia changes. Again, another case of osteomalacia with multiple looser zones, also some stress fractures also noted. Osteomalacia with increased density. Look at the heads of the femora, look at the pelvis. There is increased density, but notice in the pubic symphysis area, there are old fractures. looser zones and real fractures too. Classical example of a looser zone, because of the transscapular artery goes on along the blade of the scapula, because of the pulsations. Even the pulsations, because of the softening of the bone, even the pulsations prevent mineralization of that area. That's why this translucent area are so-called looser zone. Another example of osteomalacia under treatment, healing of the looser zones. And here, look at the film, there are fractures at the next to the femur, deformities. The pelvis is not that much affected, but still osteomalacia with deformities. Now we come to scurvy. Scurvy is deficiency of vitamin C, particularly in children who are not fed by fruit juices and all that, you may get scurvy. Of course, it's not as common as it was decades ago, but today, even then, in slums and other areas, undernutrition children, you can get and encounter scurvy. What are the radiological findings? Soft tissue swellings because of the hemorrhages. Calcification of subperiosteal hematoma. Cortical thinning because of the osteoporosis. Cankerous zone is a zone of provisional calcification which is dense at the metaphyseal ends. And proximal to it, there is a lucent band. This is the scurvy line called or Trummelfeld zone. And Pelton spurs. What are these? Cortical metaphyseal corner spurs. Metaphyseal fractures. White rim of epiphysis, so-called Wimberger's sign. That is, the epiphysis, if you take it, in the center, there is no spongosa, everything is lucent. Whereas the cortical line, like a drawn with a white pencil, it is dense. Wimberger, a long time ago, has described this. Wimberger also has described another important sign in congenital syphilis. That is, bilateral, metaphyseal, lytic changes. They are symmetrical in congenital syphilis. Epiphysiolysis, broadening of osteochondral junction, similar to almost Rickets. Cupping of metaphysis, similar to Rickets, but is not as severe in degree as you see in Rickets. Subperiosteal infraction, corner sign they call it, or a fracture. Several examples of scorbutic changes in the knees. Calcified subperiosteal hematoma, Wilkins sign of spurs, Wimberger sign the epiphysis, and then sometimes it's bilateral, sometimes it's unilateral. Often the differential diagnosis rests. Is it congenital syphilis? Congenital syphilis, you get a periosteal reaction, not subperiosteal hematoma. Is it an abused child syndrome? Either by parent or somebody else. But they are asymmetrical, and there are asymmetrical fractures. Some of them are healing because it's not one episode. Serially, periodically they go on beating. So sometimes healed fractures you see, sometimes subperiosteal hematoma you see. Now we come to the important entity, osteoporosis. Osteoporosis is an epidemic, frankly, particularly in women and older people. A progressive systemic skeletal disease characterized by bone mass and microarchitectural deterioration of bone fragility and susceptibility to fractures, easy fractures. It is a silent disease, as I said, it's a silent epidemic. Porous and fragile, fractures and disability. The morbidity is much more. Mortality is not really as a sequence of osteoporosis because of the complications. The World Health Organization has graded osteoporosis into radiologically, it may be normal, but still there is osteopenia. As the age advances, frankly, osteoporosis starts even at the age of 40 and slowly progresses until old age. The normal osteopenia, that is poor bone formation. Osteoporosis, porotic, that is because of the protein loss, osteoporosis, and of course severe osteoporosis. These are the grades. In other words, radiologically it may be normal, still the patient has osteoporosis, osteopenia, and osteoporosis, and severe osteoporosis. Generalized diminished bone density, we call it osteopenia. Osteoporosis, inadequate osteoid synthesis, protein deficiency. Senility, one of the causes. Dietary deficiency, lack of protein intake. Endocrine abnormalities, such as Cushing you can get, hyperparathyroidism you can get, disuse atrophy, and stress deficiency. You see, this I'm stressing, that's why the importance of exercise in older people. That exercise, because of muscular activity, the bones also pick up protein and we will be less osteoporotic. This they observed when the astronauts went up, journey to the moon. They didn't have any exercise. So when they came down, all of them developed a mild case of osteoporosis. Then they realized the importance of exercise. For example, in hemiplegic limbs, polio limbs, those bones are atrophic because of the lack of muscular activity. Hypoxia, idiopathic, sometimes they get osteoporosis. We don't know what the cause is. Some people say it is genetic. Iatrogenic, heparin use, steroid use, you can get osteoporosis. And sometimes congenital. It runs in families, osteoporosis. Osteoporosis generally affects the axial skeleton. But when it is severe, it may affect the peripheral limbs also. For example, take the radiograph of the hand. Classical example of osteoporosis. See, in arthritis and all that, for example, active rheumatoid arthritis, you may get para-articular osteoporosis. But here, generalized osteoporosis. Note the cortical thinning and the differentiation between the cortex and sponges. In skeleton, 80% of the bone mass is because of the cortex. And the turnover of the cortical bone is only 20%. Whereas the trabeculae constitute only 20% of the mass, but the turnover of the bone is 80%. So each is important in its own way. Particularly in osteoporosis, because of the spongiosal turnover is 80%, the bone trabeculae are resolved and the cortex remains intact. That's why you get a white pencil line drawing of the cortex and lucency in the center. Senile osteoporosis, because of the osteoporosis, the vertebrae get compressed, even without a fracture, even a physiological stress, its own body weight can produce compression fractures, resulting in kyphosis. To identify patients at risk, say generally there is a survey by bone densitometry. After 40 years, one should have, both women and men should have a survey of the bone densitometry to know the progress. Then Cushing. Steroids and skeleton, first described in 1957, then elaborated in 1959 and 1960. What are the changes? Osteoporosis, and then osteonecrosis of the bones is also common, particularly the hips, or occasionally the humerus, but any articular end can